Hello there, Dr. Buzzword here. Hope you're having a wonderful day, and welcome to this tutorial on heart failure. We'll learn about what it is, how to diagnose it, and manage it. So let's get started. So let's define heart failure. It is the inability of the heart to pump sufficiently to meet the body's metabolic demands. Classification of heart failure can be split into left heart and right heart failure, although one does eventually develop failure on both the sides. Left heart failure can be subdivided into echo imaging, into heart failure with reduced ejection fraction, HFrEF for short, and heart failure with preserved ejection fraction, HFpEF for short. There's another category of heart failure called high output heart failure that doesn't really fit in, and I will discuss more about it towards the end. To understand heart failure, it is important to understand ejection fraction. Ejection fraction is defined by the formula stroke volume divided by end diastolic volume multiplied by 100. Stroke volume is calculated by the end diastolic volume minus end systolic volume. Therefore, in someone with reduced ejection fraction, one has either reduced stroke volume or increased end diastolic volume. Similarly, in preserved ejection fraction, there will be a similar level decrease in both stroke and end diastolic volume to ensure the ejection fraction remains the same. Note that when talking about ejection fraction, we typically refer to the left ventricle as it supplies blood to the whole body. This can be measured using echo, as I described previously, or a cardiac MRI, which is more specific. The normal ejection fraction typically ranges from 55 to 70%. Now let's distinguish the features of HFpEF and HFrEF. In HFpEF, the ejection fraction is more than or equal to 50%, and in HFrEF, the ejection fraction is less than or equal to 40%. The number between 40 and 50, we tend to describe it as heart failure with mildly reduced ejection fraction. However, this doesn't need to be known in great detail for medical finals. The primary problem in HFpEF is that the myocardium has a stiff ventricle, so there's a difficulty in filling. Whereas in HFrEF, the myocardium is weak, so there's a pumping issue. The common names sometimes doctors use is diastolic heart failure for HFpEF and systolic heart failure for HFrEF. For HFpEF, the heart will have typically a thick, stiff left ventricle, whereas in HFrEF, the heart typically has a dilated, thin left ventricle. The causes are slightly different for HFpEF and HFrEF. In HFpEF, the most common cause is hypertension, aging, diabetes, atrial fibrillation, and restrictive cardiomyopathy such as amyloidosis. In HFrEF, the most common causes are coronary artery disease, followed by dilated cardiomyopathy, valvular heart disease, and viral myocarditis. A best tip to remember is reduced heart failure struggles to pump. In preserved, the heart is packed. So what happens to the heart when it is unable to meet the body's metabolic demands? The reduced cardiac output decreases tissue perfusion, and this activates the renin-angiotensin-aldosterone system. This causes sodium and water retention and eventually cardiac remodeling, specifically fibrosis and hypertrophy. In HFrEF, the heart undergoes eccentric hypertrophy. In HFpEF, the heart undergoes concentric hypertrophy, as shown in the diagrams. Now, how do patients present? You can divide the symptoms into left-sided and right-sided heart failure. Generally speaking, people with left-side heart failure presents with symptoms of pulmonary congestion. These include shortness of breath on exertion, or orthopnea, nocturnal dyspnea, and coughing up pink frothy sputum. In people with right heart failure, they present with signs of systemic congestion, which includes interstitial edema such as ascites, pitting edema, etc., and jugular venous distension, i.e. a raised JVP. Note that it's very unlikely to have an isolated side of the heart that is affected because it's a closed circuit. If the left side is affected, the right side will eventually, and vice versa. The term congestive heart failure is used when both sides of the heart are affected, and patients present with symptoms of both left and right heart failure. These are some clinical signs you may observe in patients when you're examining, such as a raised JVP, as shown in this image, pitting edema, and chest x-rays may show signs of pleural effusions or pulmonary edema in the lungs, cardiomegaly, and prominent upper zone vessels, which causes a bat wing appearance. When investigating heart failure, we typically use a combination of tests. A chest x-ray helps identify fluid in the lungs, called pulmonary edema, or enlarged heart. An ECG can show signs of ventricular hypertrophy, indicating a thickened heart muscle. The NT-proBNP blood test is crucial, as this hormone is elevated in heart failure due to strain on the left ventricle. Finally, an echocardiogram is essential for assessing the heart's function, particularly the ejection fraction, and identifying any structural abnormalities. Medical management of HFrEF is often quoted as the 4 pillars of medication. The first one is RAS inhibitors such as ACE inhibitors and angiotensin receptor blockers. A subtype is angiotensin receptor neprilysin inhibitors like sacubitril valsartan, which goes by the brand name Entresto. They are considered to be superior to ACE inhibitors and angiotensin receptor blockers in reducing morbidity and mortality. The next pillar is beta blockers such as bisoprolol. They block the maladaptive SNS activation and improve cardiac remodeling and reduce sudden cardiac death. The third is mineralocorticoid receptor antagonists such as spironolactone and eplerenone. These block aldosterone effects, reducing fluid retention and fibrosis of the heart. The final one is sodium glucose transport inhibitors SGLT2 such as dapagliflozin and empagliflozin, which is evidenced to improve mortality. The mechanisms remain somewhat unclear. These 4 pillars can be remembered by the acronym MISIS beta. Diuretics like furosemide or bumetanide can be additionally given for symptom control, but they don't offer any mortality benefit. Now, how do we manage HFpEF? Remember, the heart in HFpEF is stiff, not weak, so therapies that reduce the afterload and improve relaxation are key. The most important thing is to treat the underlying cause, such as hypertension, atrial fibrillation, etc. For fluid overload, diuretics such as furosemide can be given, and so far SGLT2 inhibitors such as dapagliflozin are evidenced to improve mortality. Now, what about high output heart failure that I mentioned previously? In high output heart failure, the heart pumps higher than normal amount of blood but cannot meet the metabolic demands of the body. The ejection fractions can be normal or sometimes even elevated. Patients present with typical heart failure symptoms, and causes include severe anemia, hypothyroidism, arteriovenous fistulas, and sepsis. The management is to treat the underlying cause. So I hope you enjoyed this video. If you did, please make sure to like and subscribe, and I'll see you in the next one.